attending. This is Dr. Wando Olaiwola from UCSF. And I'm going to just start and give a brief outline of today's webinar, and then turn it over to Rachel and Delphine to speak more specifically about certain areas. So, Bridget, if you'll get us to the next slide. So essentially what we're going to do today is first go through a little bit about just each of you and the grantees that are participating in this program, and the overall goals that the foundation has for this particular initiative with everybody. And then we'd like to just make sure that we are all speaking the same language, and have Delphine, Dr. Tuo, give a little bit of background that may be redundant for some of you, but certainly we'd like to make sure that we're all on the same page regarding the conceptual framework and the rationale for engaging in e-consultation. So we'd like to just do that before we get into the specific grantee conversations. And then Bridget will just give us an idea of what an ideal system could possibly look like based on the work that she's been doing over the years with eConsult. And then, we really want to spend some time and hear from our grantees. And as we were preparing for this webinar, we thought about some of the areas where programs and organizations that we've worked with have struggled or have found some challenge as they're implementing their own eConsult systems or programs. And we wanted to really highlight some successes that we've seen so far among the grantees, particularly in the areas of engaging the specialists and also engaging and gaining buy-in from the primary care providers as you start an eConsult program. So we're going to hear from a few of our grantees on that. And then there's certainly a question on many people's mind about what is the approach and the strategy to better engage and more optimally engage the health plans that we ultimately hope will pay for this kind of service. And so we're going to hear from one of our Southern California partners on some of the strategies that they've employed in that area. Then we will briefly, very briefly, start to touch on some evaluation metrics and recognizing that there's not a lot of time to do that, and it's probably still early to think about what those things are, but we'd like to at least give you a high-level overview of what evaluation might look like. So, with that, I hope that people will participate and engage as much as possible, particularly when we get to the grantee section. So I will turn it over now to Rachel and Carolina from the Blue Shield of California Foundation, and thank them so much for their support for this initiative.
Good morning, everyone. This is Rachel Wick. I'm a Senior Program Officer here at Blue Shield of California Foundation, and I'm here with Carolina Gutierrez, our Program Associate. Hello. We're so grateful for your work leading up to this point, and for joining us here today on our inaugural eConsult grantee webinar to really kind of begin to build the field's knowledge of what you all are undertaking through your grants and through your work in local communities across California. So I just want to talk a little bit about why the foundation embarked on our spread strategy for eConsult, and also give you kind of an overview of what's turning out to be a pretty complicated web that we're weaving to advance an eConsult spread strategy in California. Next slide, please. So none of this will come as a surprise to any of you on the phone. Specialty care access is a persistent challenge in the safety net, and an acute one pre-ACA, I would say. And the solutions that we were looking at pre-ACA, it was very difficult to move any of them to scale. Many of them were reliant on volunteer specialists and physicians or strained public hospital systems. And so I think the absence of payment was a major challenge. And with the implementation of ACA, we saw that barrier removed, which created, I think, a big window of opportunity for improving specialty access in the safety net. At the same time, that leads to an increased demand on an already stressed system. And so for us, as we started to look at the impact that eConsult was having in what I'm calling the early adopter sites in San Francisco and Los Angeles, eConsult was intriguing not only because it improved access, but it really began to better align appropriate demand for specialty care with the supply. And I think what's neat about eConsult, and this will lead to my triple aim or quadruple aim maybe outcome, the potential for triple aim outcomes, is that eConsult can really build the capacity of primary care to manage a set of conditions, better manage a set of conditions through that dialogue process. It also gets the specialty care side thinking more about population health, something we think is strong in the primary care safety net, but a newer endeavor on the specialty side. And so there are all kinds of, eConsult is kind of like the gift that just kept on giving, it felt like, in terms of outcomes. And we're excited because we do think there's promise in terms of the triple aim. So we think if you reduce the need for in-person visits, you're improving patient experience, because for low-income patients, they're not having to take off work to arrange childcare, et cetera. We think you're improving population health because you're getting access quicker, you're reducing wait times, and we hope that you're also reducing costs by reducing unnecessary specialty access visits, but also some of the reduced costs that we were hearing in terms of duplicative testing or wasted visits because certain tests hadn't been done before a patient would arrive. So I think we are in the early phases, and Delphine and Wanda will talk later about the evaluation metrics, but I think we really are on the cusp of thinking about how we can really demonstrate that eConsult has the potential to impact the triple aim. Next slide, please. So one of the things that we did is last year in August 2014, we convened the early adopters in California, but also across the country. And what we wanted to do as we embarked on an effort to spread an innovation is really understand the implementation science behind this innovation. So how were those who were successful at doing it, what is it that they did? What were the ingredients that had made their adoption of eConsult successful? And so it was a really great meeting of, we had folks from Canada, from California, from Connecticut, from Mayo, in Minnesota, just real expert practitioners. These are the doers, the people who have done it, to really surface for us what those ingredients were that we had to look for in every site that we started to work with on our spread strategy. And so this will just give you a map of our partners to date. So we, in December, we made 2 grants to our early adopter sites, LA and San Francisco, and we made 6 grants to new sites to work on planning and implementation activities related to eConsult. And so I've sort of broken them down by a couple, those 6 by a couple categories of where we are seeing kind of folks at in terms of readiness. And so we have what I would say are 3 sites that are pretty ready for implementation, and I think at least 2 of them and maybe 3 of them had started the eConsult conversation long before our grant took hold. And so, you know, for some of them, I think might have been Evan from Alameda saying, you know, we started talking about this like 5 years ago, but the systems weren't ready. And for a variety of reasons, you know, things hadn't taken off. And so I think in those counties that are more ready, it's just been there's been a longer history of conversation around the potential for eConsult. And then we have a few communities that I would call are more in feasibility assessment. And Bridget has been doing significant work around that. And some of the questions that are coming up there are, you know, we're offering essentially with eConsult the opportunity to implement a very specific solution. And I think for those who are just in the conversation about what's the potential for eConsult, and they're asking, where does it fit in this larger continuum of strategies to improve specialty care access, and including other telehealth strategies, you know, other maybe core capacities that need to be built. And so I think, who are your partners, who are your players? Those are some of the questions that folks who are in feasibility are really thinking through right now. And then we're in conversation always. I think the number has even grown with prospective new sites across California. And I think one thing that's interesting when you go into spread is we've often started with public hospital systems because we felt that they had a ready kind of crop of specialists that could serve in the reviewer capacity and have been integrated into systems. I think as we look to spread, you'll see a big, gap up north and also in that eastern corridor where there aren't any public hospital systems. And so part of what we're wondering is, what's the potential for the innovation to be adapted into some other settings, and what do we take with us from our implementation science into that next phase of work. Next slide, please. So here is this complicated web that I referred to earlier, and I'll be very quick in highlighting a couple of key things because I think you know this web well. You all are at the center of it. We're sort of constantly listening to you, seeking your advice and your input, trying to meet your needs with what would help your systems make this innovation work. And I think we're identifying some core elements through the expert stakeholders and through your experience. The big one, and I cannot stress this enough, is, and we've said this all along, eConsult is not a plug-and-play technology project. It is very much about innovating with relationships and building the relationships between primary care and specialists around how is this going to work, what are our expected practices or guidelines, how can we begin to think together about population health and how to manage the specialty access needs of the whole population. And so many of you are building your there's a whole building your champions piece of work that you're doing. You're convening meetings of these folks to kind of make sense of the system and what needs to be done. And so I just cannot stress enough how critical those convenings, that relationship building is for the success and sustainability of eConsult. And that is something we just get hammered on again and again by the early adopters. The second one, and the big one, even though I said it's not about technology, we know that technology is a really critical enabler. And so we've engaged with Blue Path, with Timmy and her team, to really look at, the vendor landscape. You all are really active in looking at that landscape. Everyone wants this integrated with their EHR. Everyone has different EHR. So, those are the kinds of issues that Timmy is working through on her end and listening again to all of you and what you need. And then we're working with both Timmy and Mario Gutierrez at the Center for Connected Health Policy to begin to really surface the policy and reimbursement issues. Some of you have asked about liability. There's some regulatory stuff. There's some plan, things that plans want in this conversation that we're trying to attend to, and what is the right way of paying for consult. So that'll be something that we're looking at. And then, as I said before, Nwano and Delphine are going to talk later, and this is going to be an ongoing conversation with all of you around shared measurement. So our goal is really, can we develop a shared measurement strategy? And eConsult has been put in our waiver, and so there's a real push around the waiver and around district to really attend to metrics, and I think we want to make sure that we've got consistent metrics to the extent we can across the sites, that we're using that triple aim, we're working toward the triple aim ones, and we think that that's kind of another way to kind of demonstrate the impact of eConsult at scale. And then finally, I have very at the bottom, our grant dollars and the wisdom from the expert stakeholders. That's sort of what's feeding this strategy. But this is a living strategy, and so if something is not up here that you all are discovering as you do the hard work you're doing on the ground, please, please, please let us know. We have, again, array of technical assistance partners. Maybe there's someone we're missing. But we want to, provide you with the complicated web of support that we know is needed to really successfully implement and sustain eConsult and the safety net. And I will stop there.
Great. I think Delphine, this was Delphine. I think I'm next. So if we can hit the next slide, please. Excellent. So thank you so much, Rachel. It was very helpful in terms of thinking about the big picture and where we want all of our projects moving. Just to take a step back, I know many of you have heard about our experience here in San Francisco with our e-referral program, but I just wanted to highlight a few aspects of it over the next couple slides, and then spend a little bit longer actually on definitions and how other programs may actually differ from ours and still be quite excellent in achieving the goals of better access for, with a better experience and less cost. So if we can go to the next slide, please. So the problem at the SFGH, as well as other institutions you may recognize, is essentially a supply-demand mismatch for specialty care in particular. So we had very lengthy wait times for in-person specialty care appointments, very inefficient initial specialty care appointments because perhaps patients were referred to the wrong specialty, or there was incomplete workup, or the referral question was unclear for the specialist who was seeing a patient for the first time. And there were many referrals or many specialty care visits that were probably unnecessary and could have been managed electronically or with some further guidance to a primary care provider. Additionally, there's inequitable triage. The way it worked previously, it was just a first come, first served, whichever fax hit the machine first, which isn't necessarily the optimal way to take care of a population of patients with specialty care issues. And lastly, primary care and specialty care delivery was relatively segregated and with very few abilities essentially to coordinate those. Next slide, please. So the innovative solution at the San Francisco General Hospital, piloted back in 2005 by one of my colleagues, Alice Chen and Hal Yi. Hal is now in LA and has spearheaded a similar program down there, which has been wildly successful as well. And essentially the program here, in response to some of the issues that I just outlined, looks as such. All primary care providers or referring providers, but I use PCP here because that's the most common referring provider, submits an electronic referral or an electronic consultation. This is the only way to access specialty care in our system to date. The referral or the referral question or consult question is reviewed electronically by a specialist, so all of the incoming questions are reviewed. Clinical data from the electronic medical record are appended to that clinical question or that referral. And after review by the specialty clinician, patients are either scheduled for non-urgent or urgent appointments, as you can see on the left-hand side of the screen, or they are not initially scheduled because the specialist provider responds back to the primary care provider or the referring provider with additional questions, with perhaps some guidance recommendations, with thoughts about how the pre-referral workup can be better completed to make that initial specialty care visit most effective. And this discussion then between the primary care provider and the specialty provider then is ongoing. And it can be as simple as one or two touches, as we say, back and forth, such that now a patient might be better worked up and ready to be seen in a specialty care clinic, and those patients will then eventually be scheduled, the yellow box in the middle of your screen. But it may also be such that a patient can get the care that they need and can have the questions answered just by virtual consultation and virtual longitudinal co-management between the primary care provider and the specialty care provider. And those patients are actually never scheduled, which is the furthest orange box on your screen. Next slide, please. And so the idea is that this now incites a paradigm shift from a focus on access to specialty visits really to access to specialty expertise. The idea being that one expert in nephrology, for example, can give expertise to a variety of different primary care providers or other referring providers who can then take care of their patients' problems at hand. Next slide, please. So in our system, this has led to multiple improvements. Notably on the left-hand side, you see that PCP satisfaction with the system was quite high. Overall, most people felt that the clinical care that they provided their patients was better after e-referral compared to pre-e-referral. And this is the percentage of responses that answered yes to that question, that clinical care had improved. And importantly, from a data or from an access perspective, wait time for new in-person specialty care appointments also decreased, in part because the demand essentially for the demand for in-person specialty care visits went down because a lot of that could be taken care of virtually. So these are data from the first of our 5 medical subspecialties that went live on our program after our pilot, which is not included in here. Our pilot was in GI, and then subsequently the 5 medical subspecialties. And you can see that wait times decreased substantially. They were not, and they still are not, at an ideal state, but that is much improved. Next slide, please. So those were just 2 examples, but overall, if you think of the impact of this system on our care delivery, from the primary care side, it has reduced wait times for primary care patients who need to access specialty care. It has enabled primary care providers to have quick access to specialty expertise and has provided case-based CME, essentially to increase or enhance the capacity within primary care to take care of specialty issues. However, it does lead to more work and more balls, if you will, in the primary care provider's court, or more things to do in the primary care medical home, which is not to be taken lightly. This type of system really mandates a strong primary care base with great teamwork and a great medical home framework, because it is more work for the primary care providers. On the specialty care side, it has also reduced wait times, and now a specialist are being held accountable for things such as access to their own care. That is important. It has led to avoidance of incorrect referrals or unnecessary referrals, improved the efficiency of in-person visits. It has formalized what previously was essentially a curbside consult, which is much better patient care, but has also been huge satisfaction, has led to huge satisfaction from our specialists who prefer to have such interactions documented. And lastly, it allows our specialists the opportunity to educate some of their colleagues and other providers, as well as to learn as new cases come in, and has increased the specialty care mix, or the case mix, in our clinics. In other clinics, it may just increase the complexity of the patient that is now seen in clinic. Next slide, please. So this was just one example, and the example that I know, of course, the most intimately. But similar to the map that Rachel had shared earlier, electronic consultation and referral programs are being piloted and sustained in some cases, actually across the country. And these are just examples of some groups that have come to us and have subsequently launched some of their own pilot programs, as well as some groups that we had interacted with earlier on when we started our own program as well. And this is not by any means comprehensive, but just to give you an example that this is occurring throughout. And we are really at the forefront of what will be, I think, a really exciting paradigm shift in the delivery of specialty care. Next slide, please. Importantly, these programs do not all mirror that of the San Francisco General Hospital, nor should they, because every group, every system, every infrastructure is slightly different. And so with that in mind, I just wanted to highlight 3 different definitions as we talk about e-consults and e-referrals and what I like to think of as an integrated electronic consultation and referral system. So I'm going to actually start with an e-referral system, which is on the right-hand side of your screen. So an e-referral is really a technology-enabled system that has the expectation by the primary care provider or the referring provider that the patient will be seen by a specialist. So it's really just an efficient way to track referrals to specialty care, and it enables better understanding, and it enables that the referral question is clear because it is now legible. You don't have to rely on a fax, essentially. And it does allow for review by a specialist in some circumstances to allow better triaging. That is essentially a referral system, an e-referral system. It does not really highlight the back and forth communication that we think of is highlighted in the eConsult system on the left-hand side of your screen. An eConsult we like to think of is a request by a primary care provider or any other referring provider for a patient's condition and treatment to be evaluated by a specialist, but does not carry the expectation that the specialist will see the patient. And so this type of interaction back and forth and discussion back and forth is really the hallmark of an eConsult. The SFGH system really takes both of these processes, the eConsult and the eReferral, and integrates them into one system that we call an integrated ECR. And this is a single portal of entry for referring providers that do not need to distinguish what is an eReferral versus an eConsult. It is just, this is my patient's condition, this is the question at hand. And all of these have then to be reviewed by a specialist. And then we like to think that the decision for whether a patient needs to be seen in person by a specialty care provider or can be managed in primary care then happens mutually with the primary care provider and the specialist provider both coming to that decision together. Next slide, please. And we have found that systems that are mainly electronic referral systems have slightly different drivers of implementation than electronic consultation systems, although some of them may be similar as well. The electronic referrals, really the main driver is for operations, it's for tracking, it's for legibility, it's for triage purposes. Electronic consultation systems are often to improve access to specialty care because of long wait times and the supply-demand mismatch, really trying to reduce that demand for in-person specialty care visits. It also enables, or one of the other big drivers is to improve communication and to enhance PCP capacity. An integrated ECR, where both functionalities are integrated into one component or one program, is really to achieve a population approach and to provide specialty care to a population. Because if you are sitting in a position where you see all of the specialty referrals coming for orthopedics or all of the specialty referrals coming for endocrinology, you have a much better sense of what your population needs and how you can better serve that population, both via eConsults, but also with other potential mechanisms as well. Next slide, please. There are facilitators and barriers to both, and I will not belabor these substantially, but essentially facilitators include engaged leadership, as many of you will be able to attest, established relationships between primary care providers and specialists, intuitive technology because it is an enabler, but clear attention to workflow because this does disrupt the way we have provided specialty care previously, and a funding mechanism for which we are grateful for the Blue Shield of California Foundation. Barriers include clinician resistance, all types of clinicians, PCPs as well as specialists. And I think lack of integration with an electronic health record is certainly a barrier, but not one that cannot be overcome. And many other groups that do not have integration with their electronic medical record with the eConsult system have been able to overcome this barrier with clear attention to workflow. Other barriers or concerns that have come up include liability from the specialist side, systems support and reimbursement for the specialty providers who are giving time and giving energy to do these electronic consultations. Next slide, please. So I think with that, I will actually transfer this over to Bridget, but I just wanted to give you a sense of what we did here in San Francisco and how other systems are similar, but it may also be different as you think about the type of system that works best for your own barriers.
Well, thank you, Delphine. I appreciate it. So good afternoon again, folks. This is Bridget, and I'm going to walk you through some basic steps in definition of terms and how we have conceptualized the different innovations that will assist in improving access at its highest level. And the conversations I've had with several of the grantees who are in this feasibility assessment mode, we've talked about it in terms of what do we need to consider, what are the actual problems that we're trying to solve, and then which technology or which approach might best fit those challenges and support improvements in those particular areas. So what I'm going to offer up in the next couple of slides is that conceptual framework. This will appear to be very familiar to our guests today from Monterey, from San Bernardino, and from San Diego, as we've been talking through that back and forth this year. And it reiterates some of the experience that San Francisco went through in implementing their system, as well as Los Angeles and others. So take it from the highest level. We're going to walk through what considerations frame your decision making and your next steps and which approaches that you're taking. So we frame it in terms of what is your system goals? Typically, what is it that you're trying to do? Where are you headed? What are you trying to accomplish? Is it actually improving access to services? Is it building PCP case management capacity, so allowing them to review these cases, manage them themselves with an additional resource at the other end of some sort of communication mechanism? Is it decreasing inappropriate referrals? So as Delphine had said, that supply-demand interface where the volume of referrals may not meet what supply is capable of. Is it about expediting a scheduling process or increasing overall communication between provider and provider colleagues? These may be specific system goals, and framed within your own delivery system. The groups that I've been working with are multi-organizational structures spread across diverse counties, and so the goals in those discussions need to follow suit as far as what is a key priority, what's a timing for that priority, and how that relationship communication mechanism happens. So in addition to your goals, you think about your system users. Who will be communicating? Who do you intend or hope to have this technology foster communication? Is it provider to provider? So the PCP is always going to be in contact with the specialist. Is it organizational, multi-role, layer to layer? Is it the MA conferring with a case manager? Is it a scheduler talking to another scheduler? Is it provider to provider? Or is it even to the point of patient and provider interaction, as you see on the opposite end of this spectrum, all the way to the point of, say, a telemedicine encounter where the patient is actually speaking with a specialist. All of these are considerations for which approach or which technology or which innovation for access that you're pursuing. The other thing to consider is then who are the players, so to speak, in your particular implementation. And these are your four classic categories. Obviously, your primary care providers, which ones are serving in that geographic area, what are their current access and referral patterns. So are you dealing with one clinic group? Are you dealing with an entire consortia? Are you dealing with multiple clinic primary care entities? Who are your specialty reviewers or specialists? What's their area of expertise, their area of focus? Why are they engaged in this conversation? Are they a recent champion? Are they really focused in on a particular disease state that they'd like to assist with? What is it that you want from them, you being those implementing the project? Are you asking for training? Are you asking for consultation? Are you asking for case management support and review? Typically, there's a gatekeeper or a system owner. And that role, in this case, that player, may be in any one of these categories. It may be a specialty location, such as Rachel had mentioned. Public hospitals might be the system owner and manage the system, the implementation, and build the expectations as the partnership unfolds. The system owner may be a third party, an entity who has been contracted and is operating the system, a consortia, a separate group. On the map earlier, there was a discussion about Access OC, Access for Orange County, third-party entity that promoted the implementation of this. So who is the system owner? Who's going to manage the technology, image capture, communication pieces? And then fourth on this list, but certainly not least, is your local health plan or plans in some cases. And I know our San Diego folks can speak to the issue about managing and working and wooing the health plans to the table. What's the classic concern for them as far as how do they define success? What would their goal be for an implementation of one of these innovations? So our framework then goes to what's the consideration, what is it that you are hoping to accomplish, what's your goal, and then how does that goal relate to a particular innovation. So as Rachel said, this is a huge investment on the part of Blue Shield of California Foundation, and started with a number of initial investments and roundtable conversations about what practices work. When you think in terms of at the highest level of an eConsult definition, as Delphine presented to you, it's a secured email closed system structure. It's that provider to specialist consultation conversation. So in the category of who's communicating, it's provider to provider, typically. The presentation of materials, tests, history, review, and then creates that dialogue for next steps. And you can see some of the top specialties that have been used in an eConsult format, that particular technology has been leveraged for it. And what you see in front of you, now no, I'm not going to turn all of you into process flow map geeks, I promise. And this is accessible, this broader flow map, but this is the ideal framework that we've talked about. What you see is you can walk through the layers or rows, primary care providers and their particular row in an eConsult interaction. They submit questions and a consultative request. It goes to the specialist reviewer, who then fosters that dialogue, and how many questions and interactions varies depending on the need for the case. Do we close the dialogue? Is an in-person follow-up needed? If that's true, the referral then may go through a gatekeeper or system owner for scheduling processes. And in an ideal state, the health plan's engagement then would be authorization might be expedited for a specialty consult or a specialty in-person encounter based on the eConsult dialogue already happening. So this is a framework to consider under eConsult. You see, again, the roles and the players, primary care providers, specialty reviewers, whoever that gatekeeper or system owner is, and then the health plan. And again, this flow map is available for access for all of the Blue Shield of California grantees. It's something we've built upon following our conversations and discussions with early adopters, as well as systems that are in early implementation mode. So e-referral, as Delphine had highlighted, also is a technology-based innovation to improve access, but the key focus or the key goal in this case is that expedited scheduling authorization process. Let's see if we can eliminate the fax backs, the paper exchange, the lack of information, pre-test might not have gotten there with the patient, and this arduous how many review steps are there without proper documentation. So e-referral creates this software, web, and email-based system that links then these distinctive organizations, the primary care providers, to the specialty resources. It stages the referral request through an authorization process. It may include similar information that you've got in an eConsult, but its purpose and its focus is I'm here to expedite that scheduling and authorization process steps. It's applicable in all specialties. It is smoothing out that communication and documentation. Now, the San Francisco program has carefully integrated that through extensive work between their eConsult and their e-referral, as Delphine walked through. Several applications have begun with an e-referral as a starting point, as a way to build the conversation between organizations and partnership, and then have moved along that technology trajectory towards eConsult. So let me just give you those distinctions again. In the flow map sense, at the highest level, you consider the primary care providers, then submit a referral request, and it stages through to a review process and creates a notification back if an in-person appointment is actually needed or not needed. It also sets up a queuing process for scheduling, and again, your health plan engagement in that, classically in the ideal state, should be expediting the authorization and prioritization of that particular request for specialty in-person appointments. So that's the framework, again, eConsult, e-referral. I throw in telehealth because we also see this category playing out. It's an actual benefit of the dialogue or communication. So I just offer this one up for you folks. Consideration on this one is, in the classic definition of telehealth, it is purposely for case review and training opportunities for primary care providers. Now, an eConsult system may have that side benefit. The number of consults is going to actually train the provider on case review, case management techniques, up-to-date protocols, etc. Telehealth, as opposed to eConsult, is sort of at the earlier stages of that, where its sole purpose is for education and case review. It's, again, software-based, and it tries to address timing and scheduling and geographic barriers. So if you can't always disappear out of your clinic for a training or a CME session, this offers you a technology-based exposure. Presentation of content happens, case-based review, but again, its intent is the training aspect, not the consultative case management, curbside consult aspect, and certainly not the scheduling for an in-person specialist appointment. So again, on the same format, telehealth fits in that framework. The framework that we've presented here, we offer up as just an ideal state sort of review and a way to think through your implementations and definitions. So just quickly, keep mindful as you move forward. I know several of the grantees are further along in this process, but be mindful as you move forward about, again, what are your system goals? Who do you hope will be communicating between using the technology, provider to provider, organization roles to organization roles, or patient to provider? And what role will the classic four characters play? Primary care providers, what role do you hope they have in this dialogue, this innovation you're implementing? Specialists, what role and how deep an engagement do you want from the specialists? Who will be the gatekeeper or owner of the system, and what skill sets and exposure and access do they need for implementation? And then how will you engage the local health plans? What do you hope for their particular work in the innovations for access projects that you're implementing? So with that, I will turn over the slides next to the grantee experiences section, and back to Nwando and Delphine.
Great. Thank you, Bridget. Thank you, Delphine, for those great overviews. I think it segues very nicely into this next section, and if you could go ahead and advance the slide, we'll jump right into the grantee experiences. I think one of the things that we have heard from the foundation itself, as well as Bridget and Delphine, is that we're really talking about building relationships. The technology is definitely important, and but we really talk about building relationships in a system where, in many cases, people have not necessarily had this kind of vehicle to come together. So it would be really great to hear from our colleagues at Santa Clara County and hear some more about how they have been engaging their specialists and what they've been doing to be able to kind of bridge some of the gaps between the primary care providers and the specialists. So I will turn it over to them and have them speak for probably about, we're running a little bit behind schedule, so I'll probably have more towards 3 or 4 minutes so that we can be sure we have time for people to ask questions and jump in.
And Nwando, who's our representative from Santa Clara?
Richard, I think Kent is on the line.
I think Kent is yeah. Kent, are you there?
Kent, I have an audio pin. I can't pull you off mute. I sent you an audio pin, so if you can dial in for audio. Shall we move forward with one other speaker while Kent is trying to dial in for audio?
Well, we also would need Evan also to get connected by audio too, because he's going to speak as well. I'm not sure if he's on the call.
I'm sorry, Nwando, tell me again.
Evan, are you on as well?
Yes.
Or maybe you don't have. Okay.
I'm on, but I'm muted.
Hi, Evan.
Okay.
Can you hear me?
We can.
Yeah.
All right, great. Okay. Oh wow, you guys put a.
Okay, so then we'll jump over to Alameda then and talk about the work of developing and cultivating trust, buy-in, and engagement of the primary care providers. So that'll be Dr. Evan Sivak. So Evan, you can go ahead.
Okay. So I just have a couple slides. I'll be pretty quick. So this is Evan Sivak from Alameda Health System. Next slide, please. Just for so we have been working for actually quite some time on developing an integrated eClinical eConsult system, and we've launched in 3 specialties as of mid-June, so we're about 2 or 3 months in. We've started with endocrinology, cardiology, and urology, and over the next year we'll be adding GI, hepatology, neurology, and probably rheumatology. Our approach to the first 3 specialties was we had working groups, some clinical working groups that formed, and they consisted of the lead specialists, and it varied from 1 to 3 specialists depending on the specialty. In some of our specialties we had very involved nursing staff as well as physician assistants. We had primary care providers from both our hospital-based clinics, our freestanding clinics, and the community clinics to share their experiences and opinion, as well as administrative support, which included Patty Porter and Tiffany Chang. I guess it doesn't mean Patty runs our EHR program, and Tiffany runs our referral center, as well as some IT support. We were meeting at least monthly. Initially, I think every 2 weeks, and then we moved to monthly. And we did it always by phone with webinar format, and demonstrated the capabilities. And the intent was to introduce all the players to the concept, vet the technology that we were developing, vet the referral guidelines or best practices, as well as the pre-written responses from the specialists. And we just wanted to get engagement and feedback from the specialists and providers. That was our process for engaging our providers. We also did a roadshow. We came to our provider meetings. We showed the primary providers multiple times what we were planning close to the launch date, and got a lot of very valuable feedback from actually those presentations, and continue to get feedback. We've been treating this as a pilot, and been encouraging our providers to give us feedback as well on an ongoing basis. Okay, next slide. So we actually felt really strongly that we wanted to do our best to try to build the integrated eConsult product into NextGen, and with just a little bit of customization, we were able to do that. As a result, all the communication is in NextGen, so it's all captured in NextGen and stored in NextGen, both from the PCP as well as a specialist. The good news is that all of our PCPs are on NextGen. The bad news is that our specialists, about a quarter of our specialists are on NextGen, but many of our specialists still are not on NextGen, so it's a challenge for them in getting them involved, but not insurmountable. With the early adopters, it hasn't been a problem at all. I think it'll be a little more challenging with the next wave. We also receive about half of our referrals for specialty care from the community clinic network in Alameda County, and they are not currently integrated into our NextGen. They also are NextGen users, but we're working on a product called NextGen Share to be able to communicate among ourselves. And then another relatively minor issue is just scanning, figuring out how to integrate scanning. Historically, when we were using just a straight-on e-referral product that we had developed, we were doing a lot of scanning, and we haven't been able to carry that over to NextGen at this point. And were you able to scan do you have another slide for me? Can you advance the next slide? Oh yeah, so this is what the integrated eConsult product looks like. So you can see at the top, you put in the specialty, and we have the specialties are, it's a structured text thing, and including the location. And when you put in endocrinology, for example, because that's one of our eConsult specialties at this point, the expected practices or the referral guidelines come up, and so they're right in the face of the primary care provider, so they can see what our endocrinologists request you do and the advice they give up front. So that's you can't get by that field without seeing it. And then we ask, what is the clinical question? So we really try, what we've heard over and over again from our specialists is they really want to know, why are you sending me the patient? So we phrase it as, what is the clinical question? And then there's space for more detail in the referral. So that's what NextGen looks like with our augmented functionality for the integrated eConsult. Okay, that's it.
Excellent. Thank you so much. I want to see, was Kent able to get connected to audio?
One moment. Yes, I'm on. Kent, you are on? Yes, you can hear me now?
We can.
Great.
And great.
Okay, well, I'm Kent Imai. I'm the medical director for the Community Health Partnership, which is our consortium of community health clinics in Santa Clara County. And we have been working with the Santa Clara Valley Medical Center, our major safety net public hospital in Santa Clara County. And I guess you wanted me to address the issue of engaging specialists. One of the missing goals on the previous slides I noticed was, and one that was very dear to the hearts of our specialists, was repatriation of patients back to the primary care physicians, because they saw, I think rightfully, that one of the barriers to improving access in each specialty clinic was the number of patients that they had been following for as often as, sometimes as many as several years, for specialty-related problems, and they were finding themselves in a position of providing primary care and unable to repatriate them back to the primary care physician. So that was a major goal, which engaged many of our specialists. Our dermatologists were interested in applying technology for the purposes of improving their access, and so that was the way that they were engaged. We have now a steering committee for eConsult, which is addressing both the eConsult and e-referral processes, and we're very thankful to Delphine and the group at San Francisco General for kind of showing us the way. We've been in a lot of conversations with Delphine Wando and the San Francisco General people, and they've been very helpful in providing us with resources, and we've been picking their brains assiduously. We now have about 25 people on our steering committee, so it's a somewhat large group, and the stakeholders include many of the leaders at Valley Medical Center as well as in the Community Health Partnership. So engagement of the leaders has been a key step in achieving what we have so far. We're meeting now on a monthly basis and are well on the way to implementing our first 5 pilot sites, and they are dermatology, GI, rheumatology, urology, and neurology. And I must say that when the word got out, the urologists invited themselves to become part of the group because they heard that this was going on and they thought it was a wonderful idea. So they were engaged by other specialists and just kind of hearing word through the grapevine. We were aided in all of this process by a process improvement project which was undertaken by Valley Medical Center, the hospital, called the Center for Leadership and Transformation, or the CLT process. And they chose as one of their major initiatives the issue of specialty access. So we fit right into that, that groove, as it were, and are working alongside all of the leaders at VMC for this. I would say that the one lesson I have learned from all of this is that because we were involved in specialty access improvement for a number of years, but it was always like the tail wagging the dog, because we were trying to lead it from the standpoint of the primary care network outside the hospital. So engaging the hospital leadership in the process improvement was a key step in moving forward. So that's all I have for now, unless you have specific questions.
Are there any questions for either Evan or Kent? Thank you both very much for sharing your work and for the excellent work you're both doing. Are there any questions for them before we move on to engaging the health plans with Nicole? Okay, so why don't we go on and have Nicole share, and then we can maybe see if there are questions again, check again with people at the end. So Nicole, I'll turn it over to you now.
So can you hear me?
Hi, we can.
Are you?
Yes.
Are you able to hear me?
Yep, we can.
Okay. So I'm Nicole Howard. I'm the Director of Programs and Fund Development with the Council of Community Clinics. I think on the slide deck you see Community Clinics Health Network. That's one of our subsidiary organizations. I think, you know, we have a eConsult planning grant. I think we're designated as one of the feasibility assessor grantees. I was asked to speak briefly about engagement of health plans, and just as a reminder, San Diego is a geographic managed care county, so we currently have 5 Medi-Cal managed care health plans. In San Diego, Community Health Group and Molina are the largest in terms of patient lives, so we started on engagement of those 2 health plans. In addition, what makes it a little more complex is there are additional health plans looking to enter the San Diego market, and I believe that the state has just recently released the RFP for this. In addition, we're looking at not only San Diego, but what about Imperial County. Both Molina as well as California Health and Wellness operate in Imperial County, and we've engaged all 3 health plans, CHG, Molina, and California Health and Wellness. What really resonated with me from the earlier discussion was the importance of building relationships, and I think that's just as important when it comes to health plans. So as an initial strategy, not only for health plans, but in some ways for all stakeholder groups, we had some either key informant surveys or, as the case with health plans, some individual phone conversations or in-person meetings before opening it up to large group meetings where we brought all of the sectors or stakeholders together. I think this was extremely important for us because while we do have at least 2 prior experiences with eConsult, one for the uninsured and another through the low-income health program, we needed to kind of move past some of the not so positive experiences of eConsult with the low-income health program. So we really started engaging health plans by asking them to describe their experience with eConsult so we could get past any barriers that they had, ask them to identify where they thought the cost savings might be, ask them to identify any appropriate specialties, really asking them what do we need to do as the grantee in order to make the case for eConsult, what would be persuasive. One of the things we proposed was a chart review at 1 or 2 health centers to look at referrals to specialists, maybe to do some type of an analysis of, you know, could eConsult have been a helpful tool in the chart review, or could the case have been handled in a different way with eConsult? And, you know, really asking them from the get-go, do they think the health plan would consider payments for eConsult after the planning period? So we were really surprised to learn, you know, especially one of the health plans that we spoke to said that cost savings, that wasn't the driver for them to participate. They wanted to participate if eConsult was something that the PCPs wanted. That really changed the direction of the conversation. We totally were not expecting that. We had planned to do those chart audits to see where cost savings might be, but it really changed our trajectory. And instead, we decided to proceed with the key informant interviews of health center medical directors and survey PCPs to see if we could show that data to make the case that PCPs felt that eConsult would be a good solution for the problem of access, and that was really elucidated in the surveys, that access was a problem that our primary care providers wanted to address with eConsult. One health plan, California Health and Wellness, is already piloting an eConsult system in Imperial with the only FQHC system in that county, and we've been working with them. They're willing to share outcomes, you know, once they get their project up and running. They're in our meetings, so we stay in touch about what we're both building to see where there might be synergies. You know, since the talk with the health plans, we've had larger group meetings that I think have gone relatively well, bringing everyone together. They've been very cordial and dynamic. All of the health plans have been willing to sit at the table. One of the health plans has come out and stated that they'll reimburse specialists during a future implementation phase. We researched the codes for eConsult. The health plan went back and checked. They don't use the particular eConsult codes, but they would be willing to pay as a regular consult. So far, I would say that the health plans are equally as engaged as the providers. I don't see any group more engaged than others. What we really need to do at this point is follow up with health plans to identify additional specialists who could potentially join our planning effort. And I guess I'll leave it there in the interest of time.
Excellent. Thank you so much, Nicole, for that. Really appreciate it, and I hope that that was useful to all the grantees as well. I'm very aware that we have run out of time, so we are going to actually defer the conversation on evaluation at the moment, and we will try to make sure that we get that information to you in other conversations that we've been scheduling anyway. So I wanted to just make sure that everyone had a chance to hear from our grantees, and I think that was time well spent. We are planning to have a few other webinars, and you should hopefully be hearing about those soon. We'd love to see if there are particular questions that you did not feel you got answered today, or there's a little bit more detail on any or all of what we spoke about that you'd like to have. We'd love for you to please send those to us. We have the next quarterly webinar scheduled for January 13th, and then I believe we have March 23rd, May 11th. So we still have 3 more in our series. Rachel, I'll turn it back over to you and Carolina to see if there's anything you guys like to say as we wrap up. But I really thank everyone, and particularly our grantees, for sharing their experiences and successes so far.
Thanks, Wando. This is Rachel. I just wanted to thank everyone again for joining the call, and for the presenters for sharing their experiences. And also, just to say, I think one of the important things that we began to talk about was, how do you make the value proposition to the different players in the system? And I think great, conversation examples today, and to the extent that you guys, as you have these conversations, can capture those themes for us, that would be great, because as we have, new folks coming online, it'd be great to have some kind of ready messages and articulations of the why for some of those different players in the system. And also just want to say that my and Carolina's inboxes are always open in terms of suggestions, again, of what you need, what you're getting, what you're not getting, what you like, what you don't like, because we really are building this kind of plane as we're flying it. So we're in deep learning, continuous learning mode, along with you and with our partners at UCSF, community partners, Timmy and Mario. So please, give us your input and feedback. And thank you again.
Thank you all. This is Bridget Cole. Once again, we have recorded this webinar for retrieval at a later date. As Wando and team had said, the remaining slides will get tabled for a future webinar in January and into 2015. We will forward these slides and all of the information back to the TA team so that they can be accessible, as well as Blue Shield of California Foundation for access for the grantees. I bid you a wonderful afternoon. Take care, everyone.